we'll be starting with our first talk, which is which is the need for extensive, expensive, elaborate lab tests and molecular diagnostic assays. Expert's view by Dr. Padmamalini Mahendradas. This is covered under Back to Basics in Uveitis Workup and its relevance in modern diagnostic armamentarium. So I'd request Dr. Padmamalini ma'am to please come on stage and deliver a talk. So this session is part of the IC, and it basically discusses the diagnostic methods in uveitis, in which we have come a long way now, and uveitis is no more dealt with steroids alone and no more an etiology-less entity. It has etiologies in most cases. We just need to find it using all the diagnostic methods smartly.
Very good afternoon to all of you. Thank you, Dr. Sumendra, for inviting me here. And I'll be talking to you on need for expansive and laboratory tests and modern diagnostic assays. Advances in medicine and technology have seen the emergence of many new investigative modalities, making it tougher for the ophthalmologist to decide what tests to order. New tests do not necessarily mean they are going to be useful in a clinical diagnosis. On the platter, we have different investigations available, either the skin test, serological test, imaging test, biopsy specimens, and molecular diagnostic tests such as polymerase chain reaction or PCR. So we need to tailor-make the investigation for each case and zero on the diagnosis. We need to remember all the tests share the false positive and false negative, understand the sensitivity and specificity of a test. Diagnostic tests have the most utility in confirming and rejecting the diagnosis. Coming to the diagnostic indications for molecular diagnostic tests such as PCR, whenever we suspect a case of an infective uveitis, or if the patient have atypical presentations, we do not know what we are going to deal with, or if the patient has multiple infections, you want to make sure which infection is there. If the patient is immunodeficient, with again, the chances of multiple infections are there. In extremes of age group with atypical presentations, when we suspect masquerades, definitely investigations plays a role. The PCR is a powerful method to amplify the specific sequence of the DNA. Normally, we take about 0.1 ml, but minimum volume of 0.05 is sufficient to carry out the test. Now, next generation sequencing helps us to find out what kind of an infection the patient has. We'll move on to the case example. The first case is a case of a serpiginous-like choroiditis. Here, 26 years male, presented with defective vision in the right eye since 2 days. History of fever of unknown origin, for which he was treated with short course of antibiotics. This was treated at center elsewhere, where the visual acuity was 636, patient had AC reaction and also the anterior vitreous cells. They also noticed absent color vision in the right eye. This is the fundus photograph where we could see the yellowish lesions in the posterior pole with ILM folds, looks like a choroiditis. The OCT, in that we could see the outer retinal changes with distortion of the ellipsoid zone. In the investigations, they noticed increased total count and ESR CRP was elevated. They investigated along the line of post-fever retinitis and all the tests were negative. They treated the patients with systemic antibiotics and steroids. Patient showed improvement and noticed the resolution of the perifoveal lesions. This is the picture when the patient presented to us. After stopping the steroids, 3 days later, they noticed extensive increasing in the lesions and they referred to us. Clinically, it looked like serpiginous, like placoid form of chorioretinitis. Systemic steroids were restarted and patient was referred to the pulmonologist to start empirical anti-TB drugs. Following 2 weeks, we could see the resolving lesions of the placoid lesions with pigmentation. we did notice linear track like lesions in the retinal periphery. The picture is different. So at this point of time, we did the AC tab for PCR, which came, in addition to the TB, the viral genome was done because of the dendritic pattern of the lesion. So herpes simplex 1 came positive by PCR. We did start the patient on systemic valacyclovir, and ATT was continued, following which we could see the 2 months post-recurrence healing lesions in both eyes. So this particular case, when a different pattern of a lesion develops, is important. We need to re-evaluate the patient and treat the patients appropriately. Next case is a case of a post-fever retinitis. A 32-year female software engineer came with the complaints of defective vision in the left eye for the past 4 days. She had performed visual fields elsewhere which showed left inferior immunopia. She had history of fever, headache, vomiting 10 to 12 days back. She had a contact with pet cat. The cat was sick at that time and no history of travel. On ocular examination, the visual acuity was 615 in the left eye. There was a defective color vision 16/21 in the left eye by Ishihara plates. Anterior segment was normal. This is the fundus examination. The right eye was absolutely fine. In the left eye, she had vitritis. There was a disc edema and peripapillary lesion was seen. Tortuous vessels were also seen. So this is a OCT showing posterior vitreous cells, subretinal fluid, intraretinal fluid, disorganized retinal layers with inner retinal thickening with aftershadowing was seen. And there was SRF and also the intraretinal fluid was seen in the fovea. Post-fever retinitis was suspected. When we did the investigations, she had increased brucella IgM was positive, serum homocysteine was elevated, ESR was raised. Urine showed pus cells, however the urine culture and sensitivity was negative. MRI brain was ordered, which showed focal enhancement of the optic nerve, suggestive of papillitis. So based on the serological titer and the clinical picture, the probability of brucella neuroretinitis was made, and she was put on doxycycline and oral steroids were continued. Follow-up visit, you can see resolving retinitis in the left eye, and there was increasing in the color vision, and the visual acuity was improved in the left eye. 10 days post-presentation, we could see the persistence of SRF and inflammations in the left eye. This is 1 month picture. By now, we got the report. This time, what happened, Bottonella came positive, which was ordered at the time of contact with the sick cat. So we had already brucella was positive. Now we got the Bottonella. What are we dealing with? So when we repeated the test of brucella, instead of increasing the antibody titer, the titers were disappeared. So then we assumed this secondary to Bottonella because the patient had history of contact with the sick cat, peripapillary lesion, and Bottonella came positive both for IgG and IgM. We referred the patient to the infectious disease specialist, and she started the patient on rifampicin and doxycycline. She continued for about 2 months. This is the follow-up 3 months picture, showed resolution of the lesions with complete improvement in the visual acuity, improvement in the color vision. So post-fever retinitis had a varied etiology, but in this particular case, history of contact with the sick cat gave us a clue with the peripapillary lesion with the neuroretinitis kind of a picture secondary to Bottonella. This post-treatment picture showed resolving retinitis. We'll move on to the next case. Third case is a challenging case. It's a case of a bilateral outer retinitis due to viral. 8-year-old boy from the southern state of Karnataka presented to a clinic with a sudden painless decrease in vision since past 3 days. Absolutely, completely blind the child. The mother revealed the history of fever and swelling near the ear the child had. But however, she did not take the child to the doctor. When we probed the history, was there any other history? Then she told the patient's sister had a fever. She took her to the pediatrician and they diagnosed it as a case of a mumps. She was put symptomatic treatment, so she gave the same tablets to this child. And also, in addition to her kids, the other surrounding also, there was a lot of mumps cases in their region. The child was vaccinated up to the age in the government scheme. Examination, hand motion was present, and color vision is absent. IOP was normal. Anterior segment examination shows corneal pigments on the endothelium. Anterior vitreous cells were seen. This is the fundus examination picture where we could see the cerebriform pattern of retinitis with perivascular clearing. It was seen in both eyes. OCT shows posterior vitreous cells, distortion of the retinal architecture, and hyperreflectivity of the inner and outer retinal layer. Left eye shows distortion of the retinal architecture with hyperreflectivity in the inner and outer retinal layers. The peripheral retina also showed the similar changes. So we made the clinical diagnosis of bilateral outer retinitis secondary to the mumps virus. So coming to the investigations, the basic investigations were within normal limits. The serum IgG and IgM we ordered. Empirically, because it's a viral, we started the patient on acyclovir, and patient was referred to the pediatric and also the neurologist. The examination, the patient went to consulted the neurologist after 4 days. So child was conscious and well oriented. By then the visual acuity has dropped to perception of light. They've ordered the MRI brain and spine and CSF analysis. MRI brain and spine were normal. However, the MRI T1 weighted axial scan showed increased uptake in the parotid gland, bilateral parotid gland. Increased uptake was noted. CSF analysis was normal. So CNS involvement of the mumps was ruled out. Patient was started on IV methylprednisolone and referred back for the follow-up. However, the patient presented to us after 2 weeks. So by then the visual acuity's perception of light and anterior segment findings were the same. The child has developed temporal disc pallor with the narrowing of the retinal vessels and sclerosis of the vessels in both eyes. So we could see the resolution of the retinitis lesions. And also the OCT outer retinal changes were started disappearing. By then we got both mumps, IgM and IgG were positive. So this patient had history of fever with parotid swelling, multifocal retinitis. OCT shows outer retinal changes. MRI showed parotid gland involvement with positive IgM and IgG antibody. We made the diagnosis of bilateral outer retinitis secondary to mumps. Patient completed the remaining dose of IV methylprednisolone, started on oral steroids. When we looked into the literature, we also noticed the Kerala group used hyperbaric oxygen therapy for the treatment of mumps retinitis. So we started this child on hyperbaric oxygen therapy after taking the detailed consent from the parents. After 2 weeks, because the patient did not improve, this is 1 week post hyperbaric oxygen therapy. We had the post hyperbaric oxygen. We felt there was significant improvement. The visual acuity has improved to 612 in both eyes. So there was hyperpigmentation near the perioral region which you noticed. Anterior segment was fine. However, we could see the chorioretinal changes, scars-like lesions started developing in the periphery. So at that point of time, because patient had increased pigmentation in the fundus and also in the perioral region, we stopped the hyperbaric oxygen therapy for 1 week. Autofluorescence shows hyperautofluorescence lesions in both eyes. FFA shows staining of the scars and the choroidal vessels, both FFA and ICG in both eyes. So due to the development of chorioretinal scars, we advise the patient to stop the hyperbaric oxygen therapy. Review the patient after 1 week. By then, we noticed there is a drop in vision in the right eye. Fundus looks more or less similar. So we restarted the patient on hyperbaric oxygen therapy along with continuation of the oral steroids. So following which, we did notice the improvement in the visual acuity in the left eye. The right eye did not improve. And this is the picture where you have a temporal disc pallor with multiple chorioretinal scars in both eyes. This is a follow-up OCT picture and autofluorescence picture. For academic interest, we did the BEP, which showed delayed latency with reduced amplitude, fulfilled ERG, undetectable photopic response in both eyes. Multifocal ERG showed light response in the central area, which is responsible for 6/9 vision in this child in the right eye. So this is a summary. History of fever and the parotid gland swelling gave us the clue, possibility of a mumps we are dealing with. Serology helps us to diagnosis and treated the patient with IBMP followed by oral steroids. Because the child did not improve as a rescue, we put the child on hyperbaric oxygen therapy and we found to have improvement in the visual acuity, especially the central vision in the left eye. So, yeah, before ordering any test, we need to ask, will it identify any underlying systemic disease or process, association, or will it provide definitive diagnosis, or it's going to reject the diagnosis, how it's going to help the management of the patient. So detailed history, thorough clinical examination still remain the most important diagnostic tool for the uveitic specialist. Avoid investigations that do not either assist in finding the cause or in the management of the condition. We need to tailor-make the list of investigations according to the clinical picture of the patient. So order expensive test only if the clinical picture demands the condition and it's not refractory to treatment. Thank you for your attention. Happy to take up any questions.
So very interesting cases, Dr. Padma. How often do you see a mixed etiology, like the first case that you showed? The patient was beautifully responding to ATT and steroids and then subsequently came with those dendritic lesions, and then you thought of a viral etiology. Because very often as clinicians, when we are dealing with a patient and we find that the patient initially whatever the presentation was and they start responding, we usually will not really go and look for some newer etiology. So that was something very observant of you, that you picked up those lesions and then you got a PCR done which came out positive, and then subsequently the patient was started on antivirals. So in your practice, how often do you really come across this superimposition of another etiology over a pre-existing etiology?
It's a rare entity. The percentage of mixed one is very, very less. I have seen with tuberculosis with toxoplasmosis, and one more case I've seen it in the past, treated as a TB and turned out to be a viral. It's important in the viral, when they start showing the changes, when you put them on appropriate antiviral therapy, we can preserve the vision. But if we miss the bus and they end up causing structural changes, then the visual improvement is not so good. But percentage of viral etiology causing SLC is less. Majority we treat them for tuberculosis.
So I think all your case examples beautifully tell us that as you go along managing the patient, probably you need to keep seeing what the patient is having, and according to that tailor-made the investigations, rather than ordering a whole battery of investigations where quite a lot of things may come out false positive also. And then probably we get totally lost at what we are dealing with.
Yes, especially for this particular child, I did not do an ACTAF for PCR. I know that we are not dealing with herpes or CMV. It's an unnecessary procedure and cost to the patient. So that's why we ordered for the serology of the mumps. And once it comes negative, so we went ahead with the neurological and other systemic management.
So thank you so much, ma'am. I think all the points were beautifully elucidated. Thank you, Manisha ma'am, for pointing